Hello everyone. Today we are going to talk about bacterial meningitis. The reason we chose it is the most common and has significant impact on the mortality and morbidity across the globe. The idea is to provide up-to-date information on this particular topic and also on other topics we discussed. We bring the most up-to-date information. Introduction. Bacterial meningitis is a worldwide health problem. Incidence is about zero point 0.9 per 100,000 individuals per year in high-income countries. In low-income countries, the incidence is hundredfold, like 80 per 100,000 individuals per year. The mortality is as high as 54% in low-income countries. So today's seminar we will talk about etiologies in neonate, children, adults, and also in immunocompromised, pathogenesis briefly, signs and symptoms in neonate children and adults, and how to differentiate viral and bacterial meningitis, and when to do imaging studies. If the spinal tap is delayed, what you need to do, what are the optimal antibiotics and the duration, and in areas where there is resistant pneumococci, what are the antibiotics, and use of dexamethasone both in adults and children, household prophylaxis for bacterial meningitis, vaccination, whether to give or not after pneumococcal meningitis, the complications in adults and neonates. The first question, what are the causative microorganisms of community-acquired bacterial meningitis in specific groups like neonates, children, adults, and immunocompromised? As you can see, the incidence of meningitis is very high in the first month of life when you're born. The most common causative organism is GBS, group B streptococcus, followed by E. coli, and other bacteria also play a role like strep pneumo, Neisseria, and staph. The incidence dramatically decreased after a month, but the representation of E. coli and GBS predominate. Then slowly, by 3 months, the GBS E. coli will become less and less. Then Neisseria and strep pneumo become the predominant pathogen in the rest of the year and also afterwards. As you can see, the incidence of Neisseria meningitis is higher early on years like 2004, 2008, and over the period of time, the incidence have decreased. And also other bacteria's incidence of bacterial meningitis have gone down significantly. But in children less than 3 months, the incidence of GBS meningitis is higher, and other bacteria are more or less remains the same from 2004 to 2011. This is data from Europe. As you can see, Streptococcus A. galactiae, which is GBS, represent 58%, followed by E. coli 21% in neonates. In children, the same European countries, predominantly Neisseria accounts for 50% of the total meningitis, and strep pneumo follows second to Neisseria in European countries. In other parts of the Western Hemisphere, as you can see, the predominant organism is strep pneumo, followed by Neisseria. And Iceland is similar to European countries, predominant Neisseria followed by strep, and Canada predominantly strep, and also the later part of the United States remains same, strep pneumo being the number one causative organism for bacterial meningitis. In immunocompromised host, strep pneumo Neisseria still can cause meningitis along with other organisms like Listeria, staph, Salmonella, and aerobic gram-negative bacilli. Outside United States, the incidence of different bugs based on the immunization status. For example, in Mexico, predominant organism between 1993 to 2003 was H. flu, followed by strep pneumo. In other areas, almost equally distributed among H. flu, Neisseria, and strep pneumo, but all those areas were pre-Hib vaccination times. How does the bacteria get into the body system? First, it colonizes in the nasopharynx, then cleaves IgA in the mucosal surface, resulting in access to the bloodstream, causes bacteremia. Then meningeal invasion happens, then release of cytokines and other inflammatory mediators, along with cell wall destruction of the bacteria itself, can invoke inflammation as well as invoke inflammatory mediators. It also affects the microvascular endothelium that can cause increased blood-brain barrier permeability, cause vasogenic edema. Inflammatory mediators can increase the CSF outflow resistance, cause hydrocephalus, thus interstitial edema, and also it can cause cytotoxic edema by directly acting on the cells. So it can cause vasogenic, interstitial, and cytotoxic edema, and also it can cause cerebral vasculitis resulting in cerebral infarction. All these can lead to increased intracranial pressure and decreased cerebral blood flow and loss of cerebrovascular autoregulation. The factors involved in pathogenesis in this slide explained in mucosal level, intravascular level, meningeal level, and subarachnoid space level. Especially the capsulated organism prevents the destruction or help them to invade all the immune barriers. Finally ended up in subarachnoid space. The host factors also play a role, especially complement, opsonic activity, and anatomical barriers. After the trauma, leakage of CSF that permeates accession of bacteria to the subarachnoid space. The second important question is, what are the clinical characteristics of community-acquired bacterial meningitis, and what is their diagnostic accuracy? Let's see signs and symptoms in neonatal period. Most of the patients will have a fever, but they can present as apnea, drowsiness, poor feeding, vomiting, jaundice, seizures, bulging fontanelle, irritability, and hepatosplenomegaly. So all these can be a presenting symptom or sign in patients less than 1 month old. This particular article published in 2015 says, what are the presenting signs? How does that allow us to prognosticate? For example, if the patient presents with apnea, chances of poor outcome is very high. Drowsiness, poor outcome is high. So does poor feeding, irritability, and also the blood parameters like low hemoglobin, increased CRP, and increased protein and decreased CSF glucose. All these can predict poor outcome in the neonatal period. What are the signs and symptoms in pediatrics? Fever, again, is more predominant, 93% of the time, not 100%, 93% of the time. Vomiting, altered mental status, headache, neck stiffness, seizures, focal neurologic deficit, and rash can present at the time of diagnosis in patients with bacterial meningitis. None of them is 100%. So absence of meningismus or neck stiffness will not and should not exclude the diagnosis of bacterial meningitis. That is a point. All of them can be a present sign, none of them are 100%. The so-called triad of neck stiffness, fever, altered mental status is not present in all patients. So it can be a different manifestation. If you have any suspicion, proceed with diagnostic and therapeutic approaches for bacterial meningitis. In adults, a little bit better. The headache is more than 85% of the patients will have headache. More than 80% will have fever. Meningismus present in more than 80% of the patients. Ultrasensorium more than 75. Vomiting, seizures, focal neurologic findings, and papilledema can be present as at the time of presentation. What's the diagnostic accuracy of algorithms in the distinction between bacterial and viral meningitis? There were lots of studies done to find out what is the test or these tests that can find out bacterial meningitis. As you can see, the 100% only with the CSF, a diagnostic tab. Presence of white blood cell, high protein, CSF lactate. Most of the time, if it is present, it confirms the diagnosis of meningitis. This particular slide differentiates whether the meningitis is bacterial, viral, tuberculosis, fungal, and parasitic. As you can see, in bacterial meningitis, it is an elevated cell count with the neutrophil predominance you will see. And protein level will be high, glucose level will be low. Other conditions that is associated with low glucose was fungal meningitis, parasitic meningitis, but the cell count will be predominantly eosinophilic in parasitic and predominantly lymphocytes in fungal meningitis. Both those conditions will have elevated protein. On the other hand, viral meningitis, which is most common, you will have mildly elevated cell count, predominantly lymphocyte, normal or mildly elevated protein level, normal or mildly decreased glucose level. With the advent of the newer technology like PCR, which is available within 1 or 2 hours of spinal tap, that pretty much identify not only viral and bacterial meningitis, it identifies the exact organism that is causing meningitis. This is a little bit in detail in smaller children because their bottom line is very different from adult CSF parameters. For example, healthy newborn will have a glucose of 30 to 120. Healthy child, on the normal CSF glucose is 40 to 80, and cell count was 30 cells can be there in healthy newborn, 6 cells can be there in healthy child, and there can be neutrophilic pleocytosis can be there in healthy newborn. So in bacterial meningitis, the serum glucose has to be done in order to find out the low glucose or high glucose is corresponding to the CSF glucose or not. In patients with the bacterial meningitis, the CSF glucose will be less than half of serum glucose. So you got to have both spinal tap and the serum glucose needs to be done simultaneously. And protein will be high, and white cell count, the CSF cell count will be more than 1,000, which is predominantly neutrophils. And the gram stain, when you do, you can identify the organism in 60% of the time. With the PCR techniques, you can really identify which bacteria is causing the bacterial meningitis. In pre-treated bacterial meningitis, most of the time, sometimes we give antibiotic, not sometimes, most of the time, we give antibiotics even before we have a diagnostic tap. In those patients, the serum glucose still will be less than half of, the CSF glucose will be less than half of the serum glucose. White cell count can be 700 to 1,000 and predominantly neutrophils and positive gram stain. That will not change. In viral, CSF glucose will be more than half of the serum glucose. White cell CSF cell count will be less than 1,000 and there won't be any neutrophilic predominance but lymphocytic predominance. Can we use clinical characteristics to predict the absence of intracranial abnormalities associated with increased risk of lumbar puncture? It's strongly recommended to perform clinical imaging before lumbar puncture in patients with focal neurologic deficit, new onset seizures, and severely altered mental status. That means GCS less than 10. European guidelines add severely immunocompromised state also need prior CT scan or prior cranial imaging prior to the spinal tap. Only the European guidelines insist. In patients lacking these characteristics, routine cranial imaging, which is predominantly CT head, before lumbar puncture is not recommended. The next question is, if the lumbar puncture is delayed, should we start treatment? The answer is, it is strongly recommended to start antibiotic therapy as soon as possible in acute bacterial meningitis patients. The time period until antibiotics are administered should not exceed 1 hour. Whenever lumbar puncture is delayed due to cranial CT, empiric treatment must be started immediately on clinical suspicion, even if the diagnosis has not been established. Delay in administering antimicrobial therapy of more than 6 hours is associated with increased mortality from 6% to 45%. And neurologic sequelae goes up from 10 to 70%. So delaying antibiotics have costs. In countries in which prevalence of Ceftriaxone resistance to strep pneumo is more than 1%, that means minimal inhibitory concentration more than 2 mg per liter, vancomycin should be empirically added to ceftriaxone pending susceptibility results. So in the United States, we automatically give ceftriaxone and vancomycin on the suspicion of bacterial meningitis. This is a management algorithm for bacterial meningitis. As you can see, on the basis of suspicion of bacterial meningitis, just make sure there are no new onset seizure, focal neurologic signs, altered mental status, immunocompromised state, so on and so forth. If it is no, draw a culture, do the spinal tap, and start dexamethasone and empirical antibiotic therapy. If it is present, don't wait for spinal tap or CT scan. Draw a culture, blood culture, and start dexamethasone and empiric antibiotic therapy. CT scan and lumbar puncture can wait. What is the optimal type, duration, and method of administration of antibiotic treatment when started empirically and after the pathogen has been identified or in culture negative patients? The empirical therapy for bacterial meningitis depends on the age and immunocompromised state and associated anatomic abnormalities like basilar skull fracture, status post neurosurgery. If the child is less than 1 month old, the empiric therapy should include ampicillin along with third generation cephalosporin or Ampangent. In patients above 1 year up to 2 years, vancomycin plus third generation cephalosporin, the same empiric therapy continue all the way up to 50 years, vancomycin plus third generation cephalosporin. These are all United States guidelines. If the patient is more than 50 years, ampicillin added along with vancomycin and third generation cephalosporin. And ampicillin is added in patients above 50 years age and less than 1 month old to cover for listeriosis. In immunocompromised state, vancomycin plus ampicillin plus cefepime or meropenem. When the patient has a basilar skull fracture, vancomycin plus third generation cephalosporin will do. In patient with head trauma after neurosurgery, vancomycin plus ceftazidime or cefepime or meropenem should be the empirical therapy. Once you identify an organism like H. flu B, third generation cephalosporin suffice. Neisseria, third generation cephalosporin. Strep pneumo, based on the geographical area, here we follow vancomycin plus third generation cephalosporin, such as ceftriaxone. When you identify Listeria monocytogenes, ampicillin or penicillin G will treat bacterial meningitis. This is a little bit in detail Even in Haemophilus influenza, whether the organism is beta-lactamase negative or positive. If it is negative, ampicillin will be curative. If the beta-lactamase positive, ceftriaxone or cefotaxime, third generation cephalosporins. Neisseria, again, penicillin MIC less than 0.1, penicillin MIC 0.1 to 1, third generation cephalosporins like ceftriaxone or cefotaxime. In pneumo, penicillin MIC less than 0.06, penicillin MIC more than 0.12, further divided into ceftriaxone MIC less than 1 or more than 1. If it is less than 1, ceftriaxone or cefotaxime. If it is more than 1, vancomycin plus third generation cephalosporin. The remaining slides talks about different organisms and what kind of standard therapy one can use against bacterial meningitis. The next slide gives a little bit more in detail different age groups, neonates, the first 7 days, first month, and beyond. It is very important to use correct dose and correct frequency in order to combat the bacterial meningitis. Memorizing is not having a sheet typed up will really helps preventing making any kind of medication errors. Does the addition of vancomycin or rifampicin to third generation cephalosporin improve outcome in pneumococcal meningitis patients in the setting of a high resistant rate of pneumococci? The recommended empiric treatment for bacterial meningitis patient is based on age and the local resistant rates. The recommended specific treatment for bacterial meningitis patients should be determined by the antibiotic susceptibility pattern in that local area. The recommended treatment for bacterial meningitis patients in whom no pathogen can be cultured should be according to empiric regimen for the minimum duration of 2 weeks. Even if the culture is negative, if you have a suspicion of bacterial meningitis, those patients need to be treated for complete 2 weeks. The committee does not recommend the short course of antibiotics in children and adults with bacterial meningitis. Because of the lack of evidence, the committee does not provide recommendation on the use of continuous or bolus administration of antibiotics in bacterial meningitis patients. Next question. Does dexamethasone have beneficial effect on death, functional outcome, and hearing loss in adults and children with bacterial meningitis? This article published in 2002 in New England Journal of Medicine evaluating dexamethasone in adults with the bacterial meningitis. As you can see, dexamethasone group, the death has been significantly reduced than the placebo group, and the disability rates kind of varies, and not much difference between dexamethasone and the placebo group. Adverse effects between these two groups are not very different, except hyperglycemia, more commonly seen in dexamethasone group, but it is not statistically different. And further meta-analysis was published in 2015, usage of corticosteroids in patients with acute bacterial meningitis. As you can see, overall mortality is better when you use corticosteroids, which is dexamethasone. Hearing loss is definitely much better in the group with dexamethasone with antibiotics than antibiotics alone. Outcome mortality in children is favorable in patients who receive dexamethasone with antibiotics than otherwise. Hearing loss in patients with H. flu meningitis definitely superior with the use of dexamethasone than those patients who did not receive dexamethasone along with antibiotics. Patient who had a step pneumomeningitis, again, hearing loss is better when you use dexamethasone along with antibiotics. In Neisseria meningitis, the same. Hearing loss is better with the usage of steroids. But non-hemophilus influenza meningitis, it is again in children, hearing loss, there is no significant effect. So clear-cut evidence is available in strep pneumo and H flu meningitis. In other areas, it's not very significant with dexamethasone and without dexamethasone. The next question is, up to what point in time is treatment with the dexamethasone indicated if antibiotics are already given? Empiric treatment with the dexamethasone is strongly recommended for all adults. 10 mg every 6 hours for 4 days. And in children, 0.15 mg per kilogram every 6 hours for 4 days. Only in the setting of high-income countries. The usage of dexamethasone along with the antibiotics is recommended currently only for high-income countries. It's not recommended for low-income countries. Treatment with dexamethasone is strongly recommended to be initiated with the first dose of antibiotic treatment. Intravenous antibiotic treatment has already been started. Dexamethasone can still be administered after 4 hours after the start of the first dose of intravenous antibiotics. It's recommended to stop dexamethasone if the patient is discovered not to have bacterial meningitis, or if the bacterium causing the meningitis is a species other than H. flu or strep pneumo. Some experts still advise dexamethasone in other bacterial meningitis. I want to caution, we do not have any evidence, especially in patients with listeria, it increases the death rate. So I think confining to H. flu and strep pneumo is the best practice. Should dexamethasone be stopped if pathogens other than strep pneumo are identified? Corticosteroids significantly reduce the hearing loss and neurologic sequelae, but did not reduce overall mortality. It's based on European guidelines. Data support the use of corticosteroids in patients with bacterial meningitis beyond the neonatal age in countries with high level of medical care. That means it's not recommended in neonatal age and also not recommended in low-income countries. No beneficial effect of adjunctive corticosteroids have been identified in studies performed in low-income countries. The use of dexamethasone for neonates is currently not recommended. The next question is, do glycerol, mannitol, acetaminophen/paracetamol, hypothermia, anti-epileptic drugs, or hypertonic saline have beneficial effect on death, functional outcome, and hearing loss in adults and children with bacterial meningitis? Routine adjunct therapy with mannitol, acetaminophen, anti-epileptic drugs, or hypertonic saline is not recommended. Hypothermia and glycerol are contraindicated in patients with bacterial meningitis. Use of intracranial pressure or cerebral perfusion pressure monitoring and treatment can be life-saving in selected patients but cannot be recommended as routine management because solid evidence is lacking and harm may occur. So at this point, ICP and CPP monitoring is not indicated routinely in patients with bacterial meningitis. Adjuvant therapy with immunoglobulins, heparin, and activated protein C is not recommended. So use of prophylactic treatment of household contacts to decrease carriage or secondary cases. It's strongly recommended to treat household contacts and other close contacts of meningococcal meningitis patients with antibiotic prophylaxis consisting of ceftriaxone, ciprofloxacin, or rifampicin. It's recommended to vaccinate with pneumococcal vaccine patients after an episode of pneumococcal meningitis and persons with CSF leakage along with reconstruction of the dural matter. Additional vaccination with H. flu and Neisseria meningitis vaccine can be considered in patients with CSF leakage. The dosage for rifampicin, ciprofloxacin, ceftriaxone are as follows. In children less than 3 months, 5 mg per kg twice a day for 2 days. Children more than 3 months, up to 12 years, 10 mg per kilo twice a day, max of 600 mg for 2 days. Children more than 12 years, 600 mg twice a day. Adult, 600 mg twice a day. Pregnant women, 600 mg twice a day, only after the first month of pregnancy, first 3 months of pregnancy, first trimester. And ciprofloxacin, adult and more than 16 years, 500 mg oral, 1 dose. Pregnancy, do not use ciprofloxacin. Ceftriaxone, children less than 16 years, 125 mg intramuscular. Adult more than 16 years, 250 mg intramuscular, again 1 dose. And pregnancy, 250 mg intramuscular. It is the first choice during pregnancy. Is vaccination indicated after community-acquired meningitis? As we discussed earlier, it's recommended to vaccinate with pneumococcal vaccine after pneumococcal meningitis, and also in persons with CSF leakage, along with reconstruction of dural barrier. Additional vaccinations such as H flu and Neisseria meningitis vaccine can be considered in patients with CSF leakage. What complications occur during community-acquired bacterial meningitis? What ancillary investigations are warranted when complications occur, and how should they be treated? As neurologic and systemic complications frequently occur during bacterial meningitis, physicians should be alert for the recognition of these complications, perform ancillary investigation upon deterioration, and initiate specific treatment when required. As you can see, in adult bacterial meningitis, 70% of them will have seizures, 14 to 25% will have ischemic stroke, and hearing loss 17 to 22%. Based on the complications, you got to do autoacoustic emission, CT, MRI, and EEG, and treat accordingly. Seizures, anti-epileptic treatment, neurosurgical intervention, and cochlear implant. In neonatal age group, seizures present almost 34% of the patients. Hydrocephalus 5 to 6%, sepsis in 24%. What follow-up of community-acquired bacterial meningitis patients should be provided, like testing for hearing loss and neuropsych evaluation? Children with bacterial meningitis, testing for hearing loss should be performed during admission. Usually it's done by autoacoustic emission, which is available in every center. In adults with bacterial meningitis, testing for hearing loss should be performed during admission. In case of hearing loss, the patient should be referred to ENT specialist in a medical center performing cochlear implant. In case if the hearing loss is not detected at the time of admission, that needs to be repeated 6 to 8 weeks after discharge. Routine neuropsychologic evaluation is not recommended at this time, but if cognitive defects occur, evaluation needs to be done and referred to neuropsychologist or rehabilitation physician. Finally, take-home points. Bacterial meningitis early recognition, prompt treatment reduces mortality and morbidity. Spinal tap imaging should not delay starting antibiotics. Antibiotics need to be started at the suspicion of bacterial meningitis. Look for the complication and address those complications immediately. Dexamethasone is indicated only in high-income countries as an adjunctive therapy. Household contacts should be traced and treated. Follow up with primary care physician and other specialists needed for hearing loss and other neurocognitive defects. This concludes the presentation on bacterial meningitis. We enjoyed doing bacterial meningitis this week. Please let us know how to improve our presentation and also what other topics we need to discuss, since we are going to do seminars every Sunday at 7:30 Central and 6 p.m. Indian Standard Time. Thank you so much.